All right, it's 1 o'clock, and I know I'm going to give people about 30 seconds before we get into the voting questions, just to make sure we have everybody back. We are going to want to have all of the CPAC folks with your cameras on so that we can see that you're available and ready to vote. And as you know, you need to be logged into the voting response software. All right. Another few seconds. Still waiting. If you are at the table, so to speak, go ahead and turn on your video so we can see that you're here. All right, we're still short a couple of CPAC members, but we really need to keep going. So I'm gonna go ahead and start off. First off, thank you again to the public commenters, the commenters from the life science companies. That was very, very helpful to lend not just context, but real substance to some of the discussion and to give different angles on it. So what we're going to do now is to focus on the voting questions. And this is going to be both short and long. There will be a short number of questions on clinical effectiveness, one, and then we will have questions on potential other benefits and contextual considerations. So if we can advance the slides, please. And just to signal that our clinical experts and patient experts who are with us are at the discretion of the CPAC. You guys can ask them questions if you would like to. I certainly will in a couple of places, but feel free to engage with them as part of this. We are going to try to really do this in a tight time period so we can leave ample time for our policy roundtable. I know none of us want to cut that short. So let me just dive right in. For patients with hemophilia A without inhibitors to factor VIII, is the evidence adequate to demonstrate that the net health benefit of emicizumab is superior to that provided by prophylaxis with factor VIII? David Rind, if you don't mind real briefly kind of summarizing the results from the ICER review on this point.
So I would just say briefly that we viewed this as a really close call. You saw that we changed the rating from B+, which would have said we did view it as adequate, to C+, which said we were less certain. A B+ requires high certainty of at least a small benefit. We don't have a head-to-head randomized trial between emicizumab and the dose of factor VIII that is currently being used. You also heard from pretty much everyone how much the feeling is that emicizumab likely is superior to prophylaxis with factor VIII because of even with the higher dosing being used, you're still talking about troughs during which people are exposed to greater risks of bleeding. We thought this was a close call.
All right, thanks. Questions or comments from the CPAC? Remember that I can't see all of you, so if you have a question, use your hand up or just dive in. Anybody?
Sure.
Yes, Steve.
So the word evidence, is the evidence adequate to demonstrate? Should we interpret that word to mean all that we've heard during the morning session or strictly clinical trial evidence?
I think evidence is the totality of evidence. Obviously, anecdotes tend to be lower quality evidence, but they're evidence.
And evidence always requires, not always, but it involves judgment of how to fill in the gaps, because there are always going to be limitations to a certain extent. I will invite, I know we don't have that much time and I want to spend most of our time on potential other benefits, but it's hard not to ask one of the patient representatives to weigh in with their view of what's been said and the evidence here. Mark Skinner, would you like to have something on this?
Sure. Thank you, Steve. And I think there's been a great summary of the information to date. I think the challenge for the panel, it was really summarized nicely in the last question, is the evidence. We have hopefully communicated through our response that patient-reported outcomes, that other elements to differentiate value are important. And that, in fact, is the space where the additional evidence is unavailable in terms of randomized controlled trials. But the absence of randomized controlled trials, we believe, does not indicate that there's an absence of net health benefit. We think from the patient testimonials, as well as the patient experience, the fact that patients are not returning to their prior therapy demonstrates that, that patients essentially have voted with their feet. They have made a decision of what to do and what's better and what's working for them. So we think that should be certainly an important consideration. And that, what I've just explained, certainly reflects my personal experience as well.
Brian, any different perspective on that?
I think a similar perspective from talking to a lot of people here who are on Emmy and from several people who've been on the clinical trial for several years. I think it's telling that 98% of people who switch to Emmy want to stay on Emmy. That's not a trivial finding. I think it will lead to greater adherence, greater ease of adherence, and also there's more leeway with the dosing day. If you're on a once weekly or once every 2 weekly regime with emicizumab, you've got some leeway in terms of dosing day itself. There's a significant, there was a lower annual bleed rate with emicizumab, even though it doesn't reach statistical significance. And I think the fact you've got greater adherence possibilities, no need for ports in children, no need for intravenous infusions on a regular basis, and less frequent dosing adds up to good evidence.
Okay. Does anybody on the CPAC want to make an argument for the other side, that the evidence is not adequate and you would like to see something else before voting yes on this? All right, given the number of voting questions we have, why don't we go ahead and please vote?
Steve, can I interrogate the other half of the question, which is how are we to interpret superior to factor VIII? Are we saying based on the population doses that we're seeing, this is not low versus high versus this is just collectively all cases of factor VIII?
I think the best way to interpret this is with factor VIII as it's used today. I mean, we've heard testimony that, okay, I'll be, yeah. And that creates the tension with the evidence that we have, but I think what we would want you to do is to think about the evidence as it should be reflected by current uses of factor VIII. All right, can we go ahead and vote? I'd just like to get a heads up from Kat or Azanta or Monica. Is our total 14, 15? 14, right?
Total should be 14, so it looks like we have all of them.
Great, let's see the results. All right, great minds think alike. There you go, well done. All right, let's go into the next quadrant of the value universe. Okay. Attendees will not have seen this exact format for ICER's voting on potential other benefits and contextual considerations before. This is part of our updated value assessment framework, and this is the first time we will be using it live in a meeting. These are always going to be a little bit bumpy because they are meant to capture and address things that may not ever be possibly measured in a clinical trial. And so we're going to work our way around some of these, but they're intended to reflect elements of value that are important to patients, caregivers, the health system, and or society that should be considered by decision makers when they are looking at the whole bigger picture of long-term value for money. So I'm going to go one by one through these rows, and we'll have brief discussion and then a vote on each of them individually. Next. Okay, so we're going to vote 1, which suggests lower value, 2, which is intermediate, or 3, which suggests higher value. And I'll just read it to you. And this is, by the way, this is about emicizumab in relationship to factor VIII. So number 1 would be a vote that you feel suggests that the uncertainty or overly favorable model assumptions create significant risk that base case cost effectiveness estimates are too optimistic. Number 3, if you vote that way, it means that you feel that uncertainty or overly unfavorable model assumptions create significant risk that base case cost effectiveness estimates are too pessimistic. And if you, in a sense, if you feel like the base case is reasonable enough and that you don't feel strongly that it's either a 1 or a 3, you would vote 2. I guess maybe I'll just reflect again, because this is around the cost effectiveness modeling. We did do conservative and optimistic scenarios. Suri, anything you'd like to just throw in real quickly as far as the approach to uncertainty? We'll let them make their own judgments about the base case assumptions per se, but around uncertainty in this model?
I don't know about uncertainty, other than we did sensitivity analyses. I think that there are some assumptions in there. We didn't have good evidence for a disutility for the infusions, for example, is one sort of assumption. Adherence is kind of overlooked in the model and can spin things another way depending on how you'd model that. We used the real world data for factor 8 from the ATHN data set that we thought matched the higher doses, but that was real world data versus clinical trial data, different than the NMA in terms of where the efficacy came from. Those I think were some major ones.
Just to summarize one element, which was the assumption around the amount of factor 8 use had a huge impact on the relative cost effectiveness, right? And you made that point quite clear.
Absolutely, because of the cost. So, the dose multiplies up the cost, very rapidly in the model.
Okay. Any questions or comments from the CPAC?
This is Jason. I just wanted to comment that I think I appreciate Suri kind of raising that issue about the disutility of the mode of delivery, which I think is something that we've heard quite a bit about this morning. I think it's not the fault of the model. These things are very difficult to incorporate into models, and especially because there was a time lag that you could imagine the disutility of the mode of delivery could lead to problems later in terms of avoidance of medical care or sort of fear or that sort of thing. I think that is a real issue. And again, it's not at all to criticize the model, because I think these things are very difficult to encapsulate in models. But I think it's something that Suri's just raised, and I think is reasonable to consider on this particular question.
Okay, thanks. Any other comments or questions? All right, why don't we go ahead and vote, please? Vote 1, 2, or 3.
And we have all 14 votes.
All right, can we see the results, please? All right, so we have 5 voting number 3 and 9 voting number 2. And these results will all be available in the final report. So we will keep going at this point to the next question. All right, I'll just read it 1s and 3s. The 1 here is a very similar mechanism of action for emicizumab to that of other active treatments. And number 3 is a new mechanism of action compared to that of other active treatments. This one seems more dichotomous, and it's hard to imagine what a 2 is. I guess 2 would be something that's similar but not very similar, something like that. David, why don't you just comment on the mechanism of action of emicizumab related to factor 8, just to remind folks the basic facts?
Yeah, this is a bispecific antibody, completely different from factor 8, but taking the role of factor 8 in the clotting cascade. It's a new mechanism. It's a new mechanism as of 2 to 3 years ago, but it's a new mechanism.
Any questions from CPAC? This one probably deserves less or needs less discussion, so let's go ahead and vote. 1 is very similar mechanism, 3 is new mechanism of action. Okay, let's see the results. Okay, you guys are getting the hang of this. Sounds good. Next question. All right, here a 1 that suggests lower value is a delivery mechanism or relative complexity of a regimen that's likely to lead to much lower real-world adherence and worse outcomes relative to an active comparator than we have been able to estimate from clinical trials. Number 3 is a delivery mechanism or relative simplicity of regimen that's likely to result in much higher real-world adherence and therefore better outcomes relative to an active comparator than estimated from clinical trials. I'll probably ask David again to make a comment on this based on the results in the ICER review.
Yeah, I mean, we spent a lot of time in our grid on this and also in the conversation. This is much easier. This is a sub-Q therapy that can be given every 2 to 4 weeks. We believe adherence will be better. As you're thinking about that, remember with infants, it's possible now without putting a port in, and nobody was putting in ports until infants were 9 to 12 months old. You could start an infant on this as a newborn. This clearly changes the calculus on giving prophylaxis.
Okay, I think we're leading the jury, but that's appropriate sometimes. And I don't think we need to invite commentary from the clinical experts or the patients on this. Why don't we go ahead and complete your voting? All right, let's see the results. Okay. 14, number 3. We have one CPAC member who's only able to call in right now. She doesn't have internet, so her vote is not going to be able to show up here. She will be texting it in to our staff, and we can add that in to the voting as we go forward. Okay? So let's go to the next question. All right, you guys, you think that these are easy. They're going to get harder. All right, so number 1 here is that this intervention could reduce or preclude the potential effectiveness of future treatments. Number 3 is this intervention offers the potential to increase access to future treatment that may be approved over the course of a patient's lifetime. A quick word of what this is supposed to mean, basically. So there are some treatments, number 1, down on that side, that might trigger an autoimmune response or do something else that would actually reduce the chance that a patient could be even given a similar or better treatment in the future, so that there's actually some risk that it could preclude the effectiveness of future treatments. There are other treatments, especially for rapidly fatal conditions, that might extend life a little bit, but enough to give a window of opportunity for patients to be alive should there be another new treatment that's just over the horizon. So this is meant to kind of capture both ends of that kind of spectrum. They're not exactly the same thing, if you know what I mean, but those are the situations that are meant to apply in this kind of situation. David, any comment on what the team had to say about this one?
I would only comment that Valrox would have come under number 1 here with a potential to reduce the effectiveness in the future. It doesn't apply to emixizumab.
Right. And emixizumab is not a kind of life extender for a short-term fatal condition, which is the kind of prototype for the number 3 here. All right, any questions before we vote? Okay, please go ahead and vote. Okay, let's see the results. Okay, interestingly, we have a couple of one number 1 and one number 3, but the mode is 12. And Jean Ryer's vote, you can add that in if you want to. I probably didn't need to name her, but now we know what her vote is. Kat, was her vote able to be received?
Yes, we have an additional vote for 2.
Okay, she kept our perfect mode going. That's good.
I
Okay.
apologize. I clicked the wrong thing. I think I'm the 1 who should be 2.
All right, you should be a 2. Does anybody want to say that their 3 should be a 2, or are you happy with a 3? All right, we'll take it as a 3. All right, next question. All right, I'll have to give you a little bit of background to this one too, but let me read it first. So a 1 that suggests lower value would be this intervention offers no special advantages to patients by virtue of presenting an option with a notably different balance or timing of risks and benefits. And number 3 is this intervention does offer special advantages to patients by virtue of presenting an option with a notably different balance or timing of risks and benefits. This potential benefit is specifically conjured up when people think about very different options for treating cancer, some of which might have a very high short-term risk of death or very bad side effect, but a higher chance of a long-term survival versus another drug that might have a very low short-term risk, but also a lower chance of a long-term survival. It's important for patients to have treatment options that offer them those kinds of choices in some cases. And so that's what is intended to be reflected here. David, any comments on emicizumab in this way?
Again, Valrox would have created a different timing of benefits, right? That concept that you could have 4 years of cure if you wanted it, and you could time that at some point. Emicizumab, if and when we learn more about what happens with inhibitors, might fall into this space. It may turn out that by using emicizumab from birth, you're shifting the time at which you develop inhibitors to later childhood rather than at birth. So there would be some ability to trade in that way. We don't know that at all.
We don't know that. We don't know that now. Okay. Any questions from the CPAC? Apologies for being fairly brisk with this. And by the way, I can't see all of you, so if you have a question, either dive in or raise your hand to some way that I will be able to notice. Okay, let's go ahead and vote. All right, the results. Okay, we have 3 people voting 1, 3 people voting 3, and 8 people voting 2. I'll just quickly ask people who are voting 1 and 3, is that, does anybody see their vote and think it was a mistake? Okay, fine, let's go forward. All right, this one should be a little bit more straightforward in terms of what it's supposed to mean. Number 1 is this intervention will not differentially benefit a historically disadvantaged or underserved community. Number 3 is this intervention will differentially benefit a historically disadvantaged or underserved community. Historically disadvantaged or underserved may be in the eye of the beholder. Those terms are obviously open to some interpretation, but this general question is meant to capture what some people feel is a societal value to prioritize treatments that may reflect, again, either a past or a current situation of disparities or other forms of being disadvantaged. David, any reflection from the team?
We used to have an other category. I sort of shoved into this one the issue about HIV and hepatitis C as a historical disadvantage that occurred to the hemophilia community.
Patient representatives, you don't have to answer this question if you think it's inappropriate, but do you think today, do you think the hemophilia community feels like it is a historically disadvantaged or underserved community?
So,
Can I answer?
Go ahead, Brian, then I'll comment.
Yeah, look, I think whether they feel that way or not, it's a fact that the majority of mortality in many developed countries over the last 30 years has been caused by the treatment. So it's a fact that they were historically disadvantaged. Now, you might say that there are very good current treatment options available for hemophilia, so we're not in a space where there are no other options, but the history says to me that the answer here should be C.
Stephen, just so a slightly different tact, and we didn't actually, I think, discuss it in this morning or in the report, but the ability to sustain an IV prophylactic regime is limited, and there are certain populations that cannot sustain that either because they don't have the capacity or the parents don't have the capacity, or at the other end of the spectrum, individuals who are living in nursing homes where the IV nursing support does not exist for people with hemophilia, but a sub-Q therapy would. So they are currently disadvantaged because the options available to them to sustain their hemophilia treatment, should they be in that type of assisted or adult care long-term facility, might not have access. So we're trying to work around that with alternative options, but ME has the potential to eliminate that that bit of I was going to say disadvantageousness, but I'm not sure quite what the word is.
All right, thanks.
Disadvantage.
Yes, okay. Any comments or questions from the CPAC?
I guess I would just comment, I do think this is a persuasive, an important issue for us to be attentive to for a couple of reasons. One of, I mean, this is way before I practiced medicine, but my understanding of this issue is that the experience of hemophiliacs really led into much better understandings of how to preserve a safe blood supply, which is something that we all benefit from. So in some sense, the society, all of us who do not have hemophilia kind of owe it to the hemophilia community to recognize this, because we sort of owe it to them, because we've all in some sense benefited from a safer blood supply that was led out of the experience of the suffering of hemophiliac. So I do think, to me, this is how you would sort of think about adjusting a willingness to pay threshold to account for this. But I think this is an appropriate place to raise this. And then I also would just kind of ask a question, which is that, again, way before I practiced medicine, but I do think there was a lot of stigma, certainly a tremendous amount of stigma at HIV, especially in the 1980s. And I wonder if the hemophilia community really, including avoidance from the medical community. So, that is a form of disadvantage and sort of discrimination.
Stephen, can I pipe in from the phone?
Yes.
This is Jean. So there are two aspects of this, in addition to the previous things that are mentioned, with which I agree, by the way. One is the incredible financial burden. I mean, think about having this much of your income devoted to care of a condition, either through high premiums or high co-insurances and so forth. And the other is that we have many states in this country that have not expanded Medicaid. We still have a large number of people without insurance and a large number of people who can't afford the insurance that's available to them. So there is a financial, I like the term financial toxicity, and it is, there's a class differential. There has to be, and that disturbs me greatly, and I hope the policy roundtable will climb into that.
It will. It will. Of course, there's an odd juxtaposition of forces here, if you will. If you're talking about financial toxicity and you wish to recognize that as a form of being disadvantaged, what we're saying here is that we should welcome a higher price for this treatment because it addresses the concern about financial toxicity. So it doesn't really, the logic doesn't work very well there. We'll come back to that. I think we've had, that's very helpful though to have different perspectives on this, because as I said, there's a piece of interpretation here that's important, but I'm glad we had the chance to hear kind of different perspectives on it. Why don't we go ahead and do the voting? So 1, again, will not differentially benefit a blank, 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 and 3 is that it will. Okay, let's see the results. Okay, we have 3 voting number 2 and 11 voting number 3. Thank you. Next question. All right. The next 2 questions are a way to address what people can either call severity of illness, burden of illness, or need. Different kind of health economists and policymakers and countries have called it different things as they use it, but it's an empirical way, one empirical way to try to look at this. So the question reads, does this treatment provide, does it address a condition for which there is a small health loss without this treatment as measured by the absolute quality shortfall? I'll say a few words about that in a second. Or is there a substantial health loss without this treatment as measured by the absolute quality shortfall? So what the quality shortfall does is it basically says over the course of a patient's life, a person's life, compared to perfect health, the health that, not perfect, but the health of the general public, How much health are they losing on an absolute basis as measured by QALYs across the lifetime? So it's a health loss across a lifetime measured in an absolute term. And the results for this analysis were run with hemophilia A patients starting at age 18, and their absolute QALY shortfall was 13.3 QALYs. And just to put that into some context, I know it's not great, but I'll start with a slightly lower number. Treatment-resistant major depression has an absolute shortfall of 8.7, which is, again, somewhat lower. Secondary progressive multiple sclerosis has an absolute shortfall of 24.5 QALYs, and cystic fibrosis has an absolute shortfall of 42.3 QALYs. So if you have conditions that are fatal, that have an even worse effect on quality of life, they will have a higher absolute QALY shortfall without a new treatment. So this is not the only way to talk about severity of illness or burden of illness, but this is one way that is being used in a variety of different organizations and, again, even countries. Any questions about this issue? I'm sure there might be. I can give you the number again, because this is in table 6.2 on page 75 of the report, but the absolute QALY shortfall for hemophilia A is 13.3. Any questions?
I have a question, Steve.
Sure.
Kara. Can you explain to me why the starting age for hemophilia A for the QALY shortfall was started at 18?
I actually am not sure. That was a choice made by the modeling team. I'm not sure if Rick Chapman is on the line, but it may have been, not sure.
Yes, that was the age of the cohort that was used in the in at least one of the models. You got a similar result if you started with a younger age for the.
Although the proportional shortfall would change, right?
Yes.
If you started at a younger age.
The proportional would, yes.
So it seems like for this drug, it's not the right age to be starting at.
Yeah, it should be a lower number.
Right.
This is Rena. I have a follow-up question to Tara's, which is, I understand that this is articulated in health loss or health benefit, but clearly there are human capital implications of this disease and its treatment, particularly for younger age groups and their parents. So, and we know that QALYs don't do a very good job of measuring those other potential losses or gains. How should we think about that?
Well, there's a question coming up about that, about the work productivity and about the caregiver effects.
Okay, but that wouldn't address the individuals themselves and their human capital decrements in terms of education or benefits in terms of education.
True. I mean, we'll probably have to take this conversation offline, but there are other benefits that are captured that are basically going to be part of these potential other benefits that we're talking about. This is a traditional health economist approach to providing information on burden of illness without the wider societal benefits kind of component.
Thank you.
Sure. All right, trying to keep our pace so that we have time for the policy roundtable in full. Why don't we go ahead and vote? Again, 1 would be small health loss, and 3 would be substantial health loss. We're going to have a vote related to the proportional QALY in a second. Okay, show the results, please. All right, we've got 1 for 1, 7 for 2, and 6 for 3. All right, thank you. Let's go to the next question. So here, the same basic setup, but here we're saying small health loss as measured by a proportional QALY shortfall, and 3 is a substantial health loss as measured by a proportional QALY shortfall. The key distinction between a proportional and an absolute is the proportional looks at the proportion that you're losing with how much you've got left. This is frequently called need, at least that's the way that the Norwegians call it. It's meant to capture, for instance, the classic situation would be a very elderly patient who on average might have 3 to 4 years left to live, but of those 3 to 4 years, they would lose 2 of them to this rapidly progressive disease. And so the feeling is, even though that the absolute loss is 2 years, that for some people, they would want to take a look at a proportional loss where you're losing 50% of your remaining lifetime to the condition. And that's a different way to think about need or severity. So here I'll just say, and the numbers are going to be a little bit foreign to you, but on a spectrum, hemophilia A comes in at 0.26. And I'm not sure how that number would change, to be honest with you. If you started it at a younger age, I'd have to think in terms of how much it would change. I'm not sure it would change that much from starting it, given that it's a lifelong condition. But secondary progressive multiple sclerosis has a proportional shortfall of 0.89, much higher. Treatment-resistant major depression is very similar with a proportional shortfall of 0.30. And cystic fibrosis has a proportional shortfall also higher at 0.62. Same issue that Rena raised is equally true here. It doesn't capture everything about what we might consider to be a burden of illness or human capital. It's focused on the health. All right, why don't we go ahead and vote, if you can, either 1, 2, or 3. All right, let's see the results. All right, fairly similar to the last one, but we've got 3 votes for number 1, 9 for number 2, and 2 for number 3. All right, we're rounding into the home stretch here. Next, please. Okay. This question is easier to interpret in some ways. Number 1 is it will not significantly reduce the negative impact of the condition on family and caregivers versus the comparator. And 3 is it will significantly reduce the negative impact of the condition on family and caregivers versus the comparator. We certainly heard from Ms. Sloboda and some of the other patients, people with hemophilia who testified about this from a family perspective. David, I know that the team spoke to a number of folks about this, and the general sense of the team was
that this, for parents of young children, it potentially has a very large effect in this way.
Yeah. Okay. Any while you guys think about this real quickly, I haven't asked the clinical experts for comment in a while. Maggie or Dr. Pipe, anything you'd like to add about this one? Caring for a lot of families as you do?
Well, on the pediatric side, it's too bad there isn't a number 4. That's what I would say.
All right. Okay, thank you. Why don't we go ahead and...
Concur.
Oh, okay, thank you. Why don't we go ahead and finish the voting then? Thank you. Okay, show the results. Okay, all 14 at number 3. Pushing the boundaries towards number 4, as you say. All right, here we go. Will not have, this treatment versus its comparator will not have a significant impact on improving return to work and or overall productivity versus the comparator. Or 3, it will have a significant impact on improving return to work and or overall productivity versus the comparator. Now, again, we're asking you to think about emicizumab versus the use of factor VIII, not versus nothing. David, what did the team think about this?
We thought it had some potential for doing this. We have some evidence in Haven, but that was not against other patients who were getting factor VIII. So we thought it might do some of this, but we certainly didn't think we had high quality evidence on the issue.
Okay.
Can I just clarify? This question is meant to, as I understand it, I just wanted to confirm, meant to isolate the effect on the patient's productivity, not a caregiver's. There are other questions for caregivers, right? This is
correct.
Thank you.
Correct. Any other quick comments, patient advocates or clinical experts? Then we can take a vote. Yes, Mark, I see your hand.
So while I agree with the way David characterized the evidence, I mean, it was one of the areas where we did have clinical trial evidence from the Haven studies that spoke directly to lost time from school and work. And then we've had other comments from the patient panelists that the ability to have freedom in the choice of work, work travel, and being able to participate fully in work without having to miss work for the infusions, I think came through. It's not RCT data, but I think there was pretty broad consensus from what we heard from the patient side that had been in the study that it had a positive impact on their ability to work and to be productive spontaneously without the consideration or reduced consideration.
And just to qualify Mark's comments on that, I believe he was first author on that study, so he's well qualified to comment on it.
Okay, great. Then why don't we go ahead and take the vote? Will not have a significant impact is number 1. Intermediate is obviously number 2, and number 3 is will have a significant impact. Okay, great. Thank you. Let's show the results. All right, 1 person voted 2 and 13 voted number 3. Great. Next question. Okay. Here we have the proverbial other, which we can, again, we're short for time, so let's just keep that in mind. But does anybody have a key other benefit or contextual consideration that they want to implant firmly in the brain of policymakers, decision makers of all types as they look at this entirety of evidence and make judgments about long-term value for money? Dr. Pipe.
There have been some discussion about adherence and its impact on breakthrough bleeding across all hemophilia treatments. But I think we haven't really touched on a really differentiating aspect of emicizumab. So if you're on a weekly regimen, because of a half-life that's around 30 days, if you, on your Monday, you're supposed to get your dose, you forget to do your dose, it really doesn't matter. In fact, you can take it the next day, you can take it 2 days later, you could probably even take it a week later, and there will be absolutely no impact on your steady state levels. And so even when adherence falters on emicizumab, it doesn't have the same resultant impact on breakthrough bleeding. But if you're on a very strict regimen with factor VIII prophylaxis, adherence becomes really critical. And lots of families are able to comply with that, but it takes a real effort to make sure. And there are consequences when you are just being late for a dose. So I didn't hear that really came out previously when we talked about adherence.
I'm curious, though, it seems to me that would be picked up in the clinical trials. If adherence is better, do you think it's because they were helping the patients be more adherent to the factor VIII than they would have ever been on their own, but in the real world, they're not that good, and so Emmy has a magnified benefit in the real world? Is that kind of what you're saying?
Yeah, in general, in the clinical trials, adherence is always magnified because of the importance of them sticking with the regulations of the trial. But in clinical practice, we're already seeing this play out, that these kinds of adherence issues with emicizumab have little to no consequence.
Okay. David, do you think it's fair to consider that as outside the realm of what was captured in the model and the clinical review?
I think we've talked a lot about adherence. The question is whether you mention it again in the way that Dr. Pipe is talking about. I think it's fair. I mean, the issue of failure of adherence as opposed to that 50 to 75% number of, gee, I screwed up and forgot to take my pill for 3 days versus, I took my sub-Q injection and it had no consequence that I messed it up for 3 days. I think that does have value.
Okay, I'm going to take the prerogative then, instead of having a formal vote on it, I think we will include that as a potential other benefit. I mean, we call them potential. I think the aspects of adherence will be something that decision makers should consider as they look at the long-term value. So we'll add that to the list. Okay, anything else people feel strongly should be included here? All right, I'm going to be ruthlessly quick then and jump out of this voting process because we are now going to take a 5-minute break. You can't take a break for less than 5 minutes, but we need one more break to head into our policy roundtable. Prepare yourselves because it's going to be a blitzkrieg of a policy roundtable, but we're going to cover a lot of really important territory. So we're going to come back exactly at 1:50 p.m. Eastern to start that discussion. Thank you very much for the votes, everybody.